All right, so I want to take a moment to give everybody the information for today's Family Medicine Grand Rounds. We have the event code listed here, 146047, and the information there I also put in the chat, the link, if you're doing from your smartphone. If you are looking for CME credit for today's session, just make sure you do so by midnight tonight. Next slide. So as we begin, we just want to take a moment to remind everybody, if you can please make sure that you are muted as we begin. Also, if you can remain attentive to our presenter being engaged in the session, and then also towards the end of the session, I'm going to be putting in the chat box the evaluation link. So if you'll please help us out and give feedback to our presenter today. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our department's mission statement is listed there for you. Next slide. CME transcripts are available at our CME website. If you do have any questions, if you're having any issues with your CME transcript, you may reach out to the CME office. Their email is listed there as well as the phone number, but you're also more than welcome to email me as well. Next slide. And also for those interested, this session does count as 1 credit for AAFP members. The information is listed there for you, so you may contact them, or you can also get a hold of me if you're having any trouble. So today, we just want to mention that Dr. Neela Patel has no relevant financial interest with commercial interest to disclose. And she's going to be talking to us today. Her topic is age-friendly health systems, what matters most. So I will let her go ahead and get started on her presentation.
Thank you, Nicole. Good afternoon, everybody. So I want to thank Dr. Persani because he was the one who suggested that I be invited to present on age-friendly health systems and what matters most. Basically, more about advanced care planning and planning to live better as we all get older. The main objectives of my discussion today are going to be to define what is advanced care planning and what are advanced directives. The two are different. To explain where, when, and how to get started, because these are not easy conversations to have. Getting older is life, and getting older is not a disease. And having conversations related to planning your life as it gets older, we're not trained in our training on how to have these conversations about life with our patients and family members and caregivers. So hopefully by the end of today's session, you'll know where we can start, how we started, when do we have these conversations. Identifying how we make shared decisions, engaging the patient, caregiver, and family in making these decisions. And they can keep changing. The decisions can keep changing also. And finally, demonstrating the impact of advanced care planning and how impactful it is for us as primary care physicians having these conversations with patients and family. Earlier, the better. So what are age-friendly health systems? So age-friendly health system was an initiative by the John Hartford Foundation and the Institute of Healthcare Improvement to, nobody expected such a increase in life expectancy and for us to live longer and longer. And despite increasing life expectancy, the quality of life really was not as good as the length of life. And so we have this age-friendly systems and 4M's framework where professionals came in together and engaged patients and caregivers and families to see what really mattered most to patients and people, and what really affected the quality of life, and what came up with is what matters most. So what's most important for one person may not be for another. Medications that patients get prescribed as they get older, the mentation, cognitive status and depression, and functional status, mobility and function, that really affects getting older with a good quality of life. So, and now we do actually add on a fifth M, and that is meals, because diet is important, and meals, basically it's mainly 2 meals or snacking a lot, but there is a fifth M now that we add on, and that's meals. So what matters most is, trying to know who the person is and aligning the care that was provided based on what the person wants for themselves and what the family and the person want together, and making healthcare goals align with what they really want for themselves. What matters most really is not just at the end of life. It should be whenever we establish care with patients, and at whatever age. We do want to talk about, all of us are getting older, and how do we want to get older. So medications, apart from just review of medications, really looking at medications from a perspective of how it matters to the person's life and to the goals that they have for themselves. If the medication is necessary, we do want to use an age-friendly medication. And basically, the number of medications that are safe as we get older is 0. The only 2 medications that are safe are Tylenol and Colace, and both are not prescribed. But we also know the reality of the situation, that as we get older, we have a lot more chronic conditions. And so we are going to be prescribed medications. So you want to look at, is the medication really necessary? Does the benefit of the medication outweigh the risk of the side effects of the medication? And how is the medication we prescribe going to affect the person's quality of life? How is it going to affect their mobility and their mentation across all the different settings of care? So not just in the ambulatory or outpatient setting, in the hospital, if you see them in rehab, in the home setting, or in skilled nursing or nursing home. So there are various definitions of polypharmacy. Some authors say 5 medicines, some say 7, and some say more than 10. But as we just discussed that, the best number of medicines is 0. So really, if a patient has a medication that they really don't need to be taking, or there is a non-medication way of managing the condition, then it is polypharmacy. So what happens when patients are on medications that are not appropriate for them, or not indicated, or causing them more side effects than benefits, is they tend not to take the medication. There can be medication errors, changes in the doses, or taking it more often, adverse drug reactions. So they are taking more than 1 medication, and the 2 medications they take. All of us do get calls from the pharmacy to verify, is it okay to give this drug? Do you know they are on that other drug, and there is an adverse reaction? And then a prescribing cascade. So they have a side effect, they have dizziness to an antihypertensive, then we go ahead and prescribe the meclizine, so that prescribing cascade continues. Or we have multiple physicians, multiple healthcare professionals taking care of the patient, and we don't know what the other person has prescribed, and the cascade just continues. Drug-drug interactions and drug-disease interactions, a medication causing a low blood sugar or a high blood pressure or anxiety, or, so there's also shown that medications are consistently associated with what we call as the geriatric syndromes, okay? Falls, confusion, delirium, cognitive impairment, hospitalization, and death. This is a picture of me actually doing a medication review for patients. And these different rows are the same medications, are medications for the same condition. And then we also sorted it out. So I have a paper that I'm trying to simplify for the patient. And there are two other papers that the patient has 3 different lists of medications. Okay. And then adverse drug reactions such as falls, delirium independently predict nursing home placement. So although polypharmacy is a geriatric syndrome, it itself results in a lot more other geriatric syndromes. So when we are thinking of medications, we really want to simplify a regimen. You want a once a day regimen if possible, rather than 2 or 3 times a day. You also want a combination. So try to see if one medication or if you get a combination medication that you can give. But before we prescribe, we really want to make sure, is there a non-pharmacological way for me to treat this condition? Is there exercise? Is there diet? Is there something else that we can do for them? Every opportunity, every interaction that we have with the patient, we want to see if we can de-prescribe. You know, is there any medication that's on the list that they really don't need? Is there something you can decrease the dose of? Is there something you can, try to combine and have only one medication? And this is more important, especially when they get discharged from the hospital or they discharged from rehab. Many times they have medications like for GERD prophylaxis and for DVT prophylaxis, and then they come out with a diagnosis and that medication stays on their list and they keep getting that medication. So de-prescribing, not losing any opportunity to change that. And here, I also want to talk about, like, it doesn't have to be just prescribed meds. These are even over-the-counter medications, because they may be safe and FDA approved, but you really don't know how that interacts with the other medications that the patient is taking. And so you really want to negotiate and try and see if they are willing to stop the over-the-counter meds also for a while and see if that makes any difference to their quality of life, to their mentation, to their mobility. Constipation is another big complaint that patients have as they get older. And the number one reason is all the number of multivitamins and the decreased water intake that they take because they don't want to go to the bathroom that often. One way of making sure that patients comply, adhere to medications, and take the medications that they really need to take can be phone in person, weekly pill boxes. And in our patient population, you could also have the community health worker or promotora help with reminding them on taking their medications and managing the medical problems. So not just looking at one condition, but looking at the person as a whole, and simplifying the number of doctors that they really need to go to. Especially as primary care physicians, I think we are the drivers of the care for the person and not just for all the different body parts. So it's important to coordinate the care and establish a relationship to where the patient then understands they really don't need to go and see so many different doctors. Mentation, we really want to prevent, identify, and treat depression, dementia, and delirium across the different settings. And so it's really important that, again, every interaction that we have with them, we do want to screen for depression. Depression not treated ends up having the same pathophysiology for dementia. So it's really important to screen for depression, and especially if they're having a UTI or something, we want to make sure they are not acutely confused and delirious. Mobility, we do want to ensure that older adults move safely every day in order to maintain function and do what matters most to them. One, for mentation, as I said, you do want to screen for depression every visit, every interaction we have with them. One thing about depression is not just sadness, but it may be a little bit of irritation, not motivated to do things, And many times the family members will say they get really very shocked and are angry all the time. So you really want to go deep into asking about depression, at least do the PHQ too. And then cognitive screening, you at least want to do it once a year. And I know it is a little difficult in a primary care clinic where we have a lot of patients to see, but maybe a minicog and training people in your team who can do these tests while they're waiting for the clinician to go in to see them. You can train MAs, nurses, to do these tests for you at least once a year, and using the EMR to help give the reminders. And I know it is a requirement for the Medicare wellness, so you want to try and do a cognitive screening at that time. Ask for depression or memory loss as well. So just as we get older, the general feeling and sense is that as we get older, pain is expected to happen, falls happen, that you do tend to forget and lose, have memory loss. But it's really not normal that, you know, you do have hearing loss as you get older, your vision is affected as you get older. These things happen as we get older and as physiological changes, but that does not mean that they are normal, okay? And that nothing needs to be done about it. We have to do something about it, otherwise it's going to affect the 4Ms. It's going to affect what matters most. It's going to affect mobility. It's going to affect mentation. So we really have to ask, because if we don't ask, they think it's normal and they're not going to volunteer and tell us that. Mobility, functional assessment every time, you know, asking about their ability for personal care and domestic care, if anything has changed, especially if they have a hospitalization or a rehab visit, you want to make sure that their functional status is the same and it has not changed. The timed up and go test is an easy test to assess mobility for those who are walking. And you want to do the test using the walker or cane. If they are using a walker cane, you want to assess what their mobility is. And if people come in a wheelchair, you don't want to assume that they are wheelchair bound. You want to ask how long they use it, or is it just because they had to walk a longer distance? And mobility, you also want to talk in terms of their ability to transfer. So mobility, you want to relate it to their functional ability as well. And you do want to screen for falls, vision, and hearing. They will not volunteer a fall information at all to us, especially if there's no injury, but those are the ones who are more at a higher risk. So you really want to screen for falls. And every visit, did you fall since the last time I saw you? Vision, especially if they're wearing glasses, you want to ask when was the last time their glasses were changed and their eyes were tested, and the same thing for hearing. So we are going to discuss about what matters most in the context of the 4 M's of aging with a great quality of life. So advanced care planning, as simple as the words say, is basically just planning life in advance, and it's mainly specific for healthcare decisions, okay? Making wishes and preferences known and letting others who matter to you know about it. Many times we assume that these discussions happen, or we don't talk about these till like the patient is very seriously ill, and the routine curative or aggressive management does not work, and the patient is needing a lot more support for mobility and function. Mentation is really not there. Their delirious are more confused, or maybe having even cognitive issues, and the medications are way too many, making the quality of life worse. So you really want, when we are establishing care and getting to know our patients, we do want to include knowing about them as a person and really what's important to them, to be able to identify what are the goals for healthcare and what would be their wishes and preferences. Here, I really want to say there is no right or wrong. Each of us are different, and we just support and value what is important to the patient and family, and find a way of how we are going to honor those values and wishes and do what matters most to them. Many times, when, especially in the hospital setting, when we're doing the palliative care consults, we hear, other team members saying, I don't know why the family just doesn't get it. They need hospice and they're not, so really it is not what they get or they don't get. It's our experiences in life shape who we are, and our culture and ethnicity, everything has a role to play in how we decide the way we want to live. And there's no right or wrong way of living as long as we know it. Many times we find where they'll say, like, even when there's an option to treat for a cancer, it is treatable, it's not terminal, they will say, oh no, I don't want to do anything about it. I'll live however long I want to live with it, but I don't want any chemotherapy, I don't want any radiation, I'm happy the way I am. And there again, you wonder, well, they have a good prognosis, and why aren't they going for it? But our role as healthcare professionals and as clinicians, and primary care especially, is to simplify, be very honest, and tell them the way it is, and give them the trajectory of how the disease is going to progress, and then help them to make choices. It never happens in one visit. You may have to keep saying it again and again, and the patient and family may think about it and come back with different preferences or wishes, and it doesn't matter. The biggest challenge I think we in the healthcare community face is where, as healthcare professionals, we sometimes don't lay out the prognosis, the trajectory of the disease, or what to expect. We give, like, many times patients tell us, oh, I got a diagnosis of dementia for my mom. They told my mom has dementia, but now I don't know what. So, like giving them, okay, you have diabetes. So now what does that mean to you? Do you know how diabetes is going to affect your body? What you need to do so that you can have a better life, and these 4 M's can be better for you, So taking the time, it's not going to be one time, it's something that we intentionally do for every visit. And it's not just the physician or nurse practitioner or the clinician. I think in interdisciplinary teams, you have care managers, we have our community health workers. We all have to speak the same language and see where the patient and family need the support. Okay. So it's making it includes decisions related to healthcare. It also includes legal planning, identifying your spokesperson who's going to represent you. It requires financial planning also. The longer you live with chronic conditions, it is going to affect function and mobility, dependence for personal and domestic care. And that all requires money, especially for those who have retired, have fixed incomes, and you're going to live on limited resources. You've got to plan how far to stretch out those financial resources, and care plans for life, how you want to live. As long as you're independent, this is how I want to be. Many of my patients, as soon as they come, they'll say, I came here because they told me y'all help us to live in our homes as long as we have life. And so basically whatever is the care plan that they want and how we can support them. And many times it is possible, and that is our goal, where we can support our patients to live at home. But there are times when that is not possible. But we have to be honest and tell them that, I wish I could do that, but in your situation, that's really not possible. And this is why. But if you still want it, we can try it this way. You give them the choices. What's the best that's going to happen and what's the worst? And tell them to think about it, and be available and accessible to answer their questions and walk this journey. This is a journey, and this is life. Advanced directives, on the other hand, are a legal document. Okay, this is a legal document that has three different things that need to be done. One is a medical power of attorney, identifying a person who would represent your wishes and preferences. It can be one person, two people, three people, who will come first, who's second, who's third. Can be related, not related. It's just somebody who knows you well, who you trust, who will be willing to represent you and express what your wishes and preferences are. And these can be written out as well. So that's the medical power of attorney. The next is preferences and wishes. And the next few slides, I'll go through the details of what this would entail. There is no, it can be really very open-ended and very detailed. I have a few patients who have like 10 pages of their preferences and wishes, and they've written details of everything. If they were to have a stroke and they had chances for meaningful recovery, then they do want to be admitted and they do want to try rehab. But if they were to have a stroke and be very dependent and live like a vegetable, then they do not want, they want to be just kept comfortable. So some patients write everything in detail, and some patients will just say, oh, my children know what I would wish for, and so I will leave it to my children to decide when that time comes. And then the third thing is the out of hospital, not resuscitate. So in the advanced directives, which is a legal document, the medical power of attorney and the preferences and wishes are things that come into play when the person is living, when the person is alive. The out of hospital DNR is when natural death has occurred. The person has stopped breathing or the heart has stopped beating. So this is an important discussion to have with patients, because often they confuse out of hospital DNR to mean not to treat. Okay, so letting them know that the first two are when you're alive, you're breathing, your heart is beating, you're living, but you're just not conscious enough to give us or talk to us or communicate with us. But the third one is you've naturally died, and do you want your chest to be compressed or to be hooked to a machine to live on machines? That's basically how you say it. So as I said, somebody you trust who represents you, and many times the patients understand that, but the person who is the medical power of attorney will think that it is their wishes and preferences, and we've had to tell the children, no, it's not what you want, even though you have the medical power of attorney. It is what your mother told you that she wants for her, or what your dad told you that he wants for him. And there are the preferences and wishes, all the directives written out, that really helps us to understand, what the wishes and preferences were. And so you really want somebody who will be the spokesperson. So many times we find it's either the youngest child or the middle child, or whoever the patient feels is the one who's going to represent them and follow what their wishes are. So preferences and wishes are basically types of decisions that might need to be made, and considering those decisions ahead of time and letting others know, both the family and the healthcare team. It's important even for the healthcare team to have it. And so many times our patients say, yeah, they have it, and it is, it is locked in their security or something. And we have to tell them, can we please have a copy of it? Okay. And it's all about preferences, values, and wishes, and how they want to live. So many times people mistake advanced care planning as planning to die. And actually, it is not planning to die. It is planning to live. And you don't have to wait to get older to plan how you want to live. I mean, I tell everybody, we are such creatures of habit and celebration. We celebrate everything. We celebrate birth, we celebrate graduations, going to school, college, baby showers, bridal showers, and all. But then we don't celebrate life in terms of, okay, as we are getting older, we have chronic conditions, and how do we want to live and celebrate life for whatever life is for us? So I say that advanced care planning is basically celebration of life, and that you don't have to wait to get older to have that celebration. You can have it and it's better to have it when you're healthy and well and in a right frame of mind to truly express what your wishes and preferences are than when you're in a hospital in pain, hooked up to machines, and too tired to even express what is it that you really want, that you leave it to people who may not represent you for who you are. So the shared decisions or the preferences are basically, one is related to resuscitation, but also feeding when you're not able to eat and drink, about feeding tubes, and much more in people with dementia. As a progression of the disease, feeding is going to be an issue, swallowing is going to be an issue. And that is way towards the end of the disease trajectory. And having a feeding tube is actually going to harm the person rather than help the person. And it's not going to provide the nutrition that they need. As a part of progression of the disease, they have dysphagia, and then the feeding tube is not going to reduce the risk of aspiration. So when a person is diagnosed with dementia, if you go through the trajectory of this is early stage, this is what happens in middle stage, and this is how it's going to be at the end, and the body's needs for eating and drinking is also not going to be as much, then it helps them to make a better informed decision of, no, I really want it, or no, I still think I don't want to let my love, I don't want to be starving, so I do want that too. Okay, but having that discussion and educating them about it. Discussions about hospitalizations, especially for patients with like myelodysplastic syndrome and all that, they would need blood and blood products and transfusions and hospitalizations for getting those transfusions. Explaining to them what the disease is, how it's going to affect their life. Again, retracing and focusing back to the 4 M's and what matters, how it'll affect their mobility, their mentation, their function, and all that. And giving them choices and telling them there is no right or wrong about the choices, but their choices should be congruent with what they feel right in the heart, and to just follow the heart. I generally tell my patients, listen to everybody, but go by what you think you want in your heart. You don't have to get influenced by what somebody else is telling you. Deep in your heart, just tell me, what is it that you really want? What is it that you want for yourself? And then many will say, for me, I really don't, when I'm gone, I'm gone. I don't want to be hooked to machines or anything. But my family, they want me, they don't want me. They think I'm giving up if I say that. They want me to get. And so I have the conversation and I tell them, okay, this is what you want. You stick to what you want. You've got to tell your family about it. And I say, do you prefer that we have this conversation together when they are also there, so that you can tell them, and if you need any support, we're here to support you, and we can explain it to them the way we explain it to you. And some of them say yes and some say no, but so each person is different. There is no notes or an algorithm or something that can be given for planning life. Each one's plan is different, and things change as we get older. Especially the more number of chronic conditions you have, the more likely there's going to be a change in daily living and the 4 M's. The questions about dialysis, especially for patients who have diabetes and chronic kidney disease, you do want to say, if the diabetes control gets worse, your kidneys will not function and you're going to need dialysis. Is this something you want? But you don't wait till they're CKD 4 or almost 5 and they need that shunt to have this conversation. You have this conversation the day you know this is your patient and this patient is diabetic. You've got to really tell them what to expect. Pacemakers, donation of organs, if they would like any organs to be donated. So especially for persons with dementia and all that, we do ask them about the brain donation for research, participation in research. And many, many times the spiritual preferences is something that we are not trained in, that we are not very comfortable in talking about. And a lot of patients and physicians and healthcare professionals think that spiritual preference and religion are the same. They're not, they are different. And so trying to explain that. And if we are not comfortable with talking about it, at least having a team member on whom to refer to have that conversation. But it is a conversation that must be had and a preference that must be known. So out of hospital DNR is, as I mentioned before, when natural death has occurred, basically says that if I'm dead naturally, I do not want to be hooked up to machines. So when, where, and how to start. Okay, so as I said, when we have a diagnosis, we want to say what to expect. And I know we have a lot of patients with a lot of different diagnoses, but we do know the person and we do know what their medical history is. You want to try and see how that is going to affect this person as they get older and how it's going to affect the 4Ms for the person. Try to get to know the person. So generally, whether a known patient or a new patient to me, every time I see them, I always ask them, so what's a day for you like? What do you do from the time you wake up till you go to bed? What's your motivation for life? What keeps you going from one day to the next? What brings a smile to your face? Just to get to know the person, even asking what was their job, what will they do, are they happy? What happy memories they have that make them feel good about themselves and their life. It's the relationship, it's the bond that we cherish as family physicians and primary care healthcare personnel. I think it's not a one-time thing, and every time you learn something different. And now we do a lot more home visits, and I can tell you it's so much more knowing the person, where they live, and what's important to them. It's a different relationship. They open up a lot more, and then they feel much more comfortable with sharing what's important to them with you. But in a 15-minute, you can do it. It hardly takes 30 seconds to ask, hey, what's a day for you, or what motivates you, and then making that connection and starting with that the next time. So I do have in my notes, I do at the end write what I have to ask them the next time they come, so that I don't forget the conversation we had, and I do remember what's important for them. Then, so with all our chronic conditions, whether diabetes or heart disease or COPD, Parkinson's, dementia, strokes, we really want to know and tell them what does this diagnosis mean to you? Do you know how this is going to affect your life? Do you know what happens if you don't take your medications? Do you know what will happen if you do not exercise? And focusing on that a medication is not going to fix it. As we get older, there are changes physiologically in addition to the diseases we have. So focusing on the non-pharmacological ways of keeping the 4Ms the way you want them to be. And people with a family history, you do want to have cancer or dementia or CAD, dialysis, whatever, end-stage renal disease. You do want to know, have the conversation like, okay, so what happened, especially patients who had family members who've been on dialysis or end-stage renal disease, and how did they handle it? What did they feel about it? That's how you get to know the person. We many times run into the situation in the hospital where we don't know what the person wanted, and now they're not able to communicate with us. And then we're trying to ask the family and friends, like, okay, what happened to their siblings or anybody else in the family go through something like this, to try to get to know the person. So we really need to start ahead of time. And still, if you've not started, it's never too late. Anytime you can have the conversation, it's a good conversation to have. And the earlier we begin the conversation, the better life the person and family members going to have. I think that makes our life as healthcare professionals better too, because it makes us feel good about what we do for the patient, honoring their wishes and making their lives just the way they want it to be. So shared steps to engage. So at the time of diagnosis, as I mentioned, is the patient aware of the diagnosis and the prognosis, and making the material very simple, in simple terms, and trying to get material. So the problem with having all these pamphlets and brochures and all about the different diseases and conditions, it is all very general. And to get to know the person and to have the person engaged in the decisions related to their care, we really need to make it very person-driven and very person-centered. So you really got to know more about the person. So in simple terms, like for example, for diabetes, I'll just tell them, diabetes means your blood has a little bit more sugar. When the blood has a little bit more sugar, it means the blood is thicker. So as it is passing through your different blood vessels, it is scraping the blood vessels, and that's what's forming the plaque. And that's why you have the blockages in your arteries in the leg, and it could affect your heart. So that's why it's important to make sure that you keep to a diet, that you take your medications, that you control your blood sugar. And just telling it once doesn't help. We only listen to what we want to hear whenever we go to our doctor's offices. So they have to hear it from every team member, and they have to hear it again and again. And then suddenly it hits them. Okay, if I don't do something about this, then I'm not going to be able to live my life the way I want to live. Okay. And so making the patient aware of where they are, being very real about, okay, the education we give for a person whose hemoglobin A1C is 7 and who's pretty good with exercise, diet, and taking medicine is going to be a lot different than somebody whose hemoglobin A1C is 12. Okay, so we cannot just give the same education to everybody. Then you also want to have what present or future experiences are most important for them to live well at that point in their life. Okay, so things change. Life is dynamic; it's not static, and so that's why we need to keep checking. And I think that's where the chronic care management goals and trying to identify goals for the person every year is an important thing. What fears or worries about the illness or medical care that they have, and what sustains the patient family during serious challenges in life. Is there anything that would be worse than that for them? Is something that we can ask. So these are things that we just don't have as an interaction during a face-to-face encounter. These could also be things that could be questionnaires for them that they could answer, that you would engage the care manager or the community health workers in whatever be the situation, but trying to find, and we also have behavior health consultants, and you can work with them to help bring about a change in behavior, especially for lifestyle changes for chronic conditions, that you can have these questions answered. So it's more ways than one. You're not just putting everything on the MDs and NPs. You're having a whole team to help you and support you with this. So there is a role for the physician healthcare team, and some of the things that the patient and family caregiver, you want to educate, be transparent. Okay. So one of the things my patients tell about me is that sometimes when they haven't done their part of exercise or taking their medications well, they're a little scared to come for the appointment because they know I'm going to ask them whether they did it or not. But at the same time, they tell me that they appreciate me being honest and being very transparent and candid about what to expect and what their role is and what we can do. Okay? So being very transparent with what to expect. Majority of the times, we are not very comfortable as healthcare professionals in telling things as they are. We fail to tell what our patients need to hear, and we tend to just keep quiet and say that, oh, they're just not ready. Okay, nobody's ever going to be ready. We're going to have to find a way to be compassionate and yet be very candid and honest. I always say, like, I experienced, my brother-in-law had a heart attack in 2004 in Houston. And the worst experience we had was waiting and waiting and waiting for the doctor to come. There was no communication at all. And so that was something that hit me really very hard. And so when I do hospital rounds and everything, I make so sure that I'm telling the patients and families, this is the time we usually round. And if you're going to be later or something, we will let you know. But I think, and they were not being honest in telling us what was wrong with him. So it's really so important. Imagine that this could be our own family, and what is it that we want. What we want for our family, what we want for ourselves is what we should provide for our patients. Listing the resources. It is a team. We can't do this alone, and we do need a team to help us. And we should do what we are good at, and delegate what our other team members are really good at. So we need to build a team. The team really doesn't need to be physically there. And I will show you how we have developed a virtual team of resources for our patients and family, and giving choices for treatment and options. We may feel that this is the best option for the patient, but if that's not what they want, it's still fine for us to honor what they want and go ahead and provide what they want. But we can't stop the education. We can't stop telling what to expect. We can't stop looking at the right resources for them. And then talking to them also about research and clinical trials, especially in situations where our treatment options are very limited. The patient and family, you want them to list who is important for making wishes known, identifying their medical power of attorney, legal planning, and financial planning. So the model of care that we developed together as a team, and it didn't happen overnight, it took us a few years, and it shaped in how we established the relationships with all our different resources, is what we call as the Carinos approach, or the Carinos model of care. Compassionate, coordinated, comprehensive care across all different settings that meets the needs of older adults. You advocate for patients and families with other clinicians and healthcare partners. So very often we do have other consultants also reaching out to us, and we reach out to them on behalf of our patients. When I say we, it could be the clinicians individually, or you can delegate somebody in your team to do that. Respecting what matters most to older adults. Our choices need not necessarily be their choice, and to be able to accept that that is their choice, you've got to be comfortable as a clinician that you have said everything the person needed to know in ways that they understand, and you're still okay with the decision they've made, and respect and support that. Intentional redesign of processes and activities to meet older adults' needs. So life is a journey, taking our healthcare is a journey. We are never going to be done, or never going to say, oh, we've mastered this process, because life is dynamic and things keep changing. So we've got to keep looking at, are we doing what we need to do and providing the resources that our patients need? Nurtured relationships with families, social service agencies, and community partners. So we, over the years, have developed relationships with not just the hospital, ER, nursing homes, home health agencies, hospices, senior centers, libraries, Alzheimer's Association, the Mace Cancer Center, BEGS, all the consultants, not just in UT, but outside of UT as well, all the DME companies, or anything that our patients need, and the social work agencies like the Senior Path Associates to be able to help our patients. So we do need to develop the relationship and keep these relationships alive to be able to help our patients. And really, I cannot emphasize enough, our patients really know what they want, and we just need to listen to them. Most of the time with older adults, what happens is we end up looking at the caregiver or the family member who has accompanied them, and we do not pay attention to the person. But if we just took a step back and we listen to what they have to say, they will tell you what they really want, and we just need to support them. And then supportive care for the patient and family. With all the chronic conditions, there is going to be a time in life when treatments are really not going to work the way we want them to work. And we just are going to be at a level and stage where we want to manage symptoms. And that's where it's beyond prescribing a medication, and it's more social, spiritual, mental support that the patient and family is going to need. And that's where supportive care comes in handy. So this may appear to be a very simple, but as you can see, it is a very complicated relationship. At the same time, you can keep it as simple as you want it to be, but there has to be a communication. It's not just linear. It's amongst all the different partners and teams that you have. And we started with the hospital, then with the rehab and long-term, then with the home health. And then with all the different consultants and the local resources, area agency for aging and all that. And then we realized despite all of this, we were still missing something. And that's when we started the home visits and going to the patient's home as well. So this is a model that can be implemented and adapted anywhere. These are processes in place that you have and resources that you build virtually to have an approach for the older patients. So I think we have like about 10 minutes. I did want to open up to questions, but the scenario that I did want to discuss is you can just think of any patient, any age, and insert a diagnosis and see how you would like approach the patient to start having these conversations. So simplifying things. So Nicole, are there a lot of questions in the chat?
I don't have any just yet.
Okay, so if anybody has any questions, we can start with that.
How do you ask about spiritualism versus religion?
So I basically tell them like, I'm asking you about spiritual health and are you at peace with yourself? And are you at peace with the universe? That's basically what I ask them. And Nicole, I think you've seen me ask that with patients when you
Yes,
work.
ma'am.
Yeah.
I do have someone who's asked if you can share your list of community resources.
Yes, we'll have Mary, our practice manager, send you all the resources that we have for our patients. And I think Julie Bryan, our care manager, also has a list of resources. So we'll share that with you.
I have another question about, so you ask about what they want for their end of life care whenever they are still able to make those decisions before the dementia gets worse and that kind of stuff. At what point do you know to no longer listen to the patient and what they're saying because their dementia has taken over, if that makes sense?
So basically, when they have dementia, they still know what they want and don't want. It's just sometimes what they communicate may not come across as what they really want. Until you can prove what the person is telling you does not make sense or is not in the person's best interest, you still ask the person and take care of the person. It's the very advanced dementia where they are wheelchair or bedbound and are not able to communicate their needs. That is when you will only look at what they have expressed before, what you know about the person, and what the family tells you about them.
I do have somebody, they've asked if there's ethics credit for this talk. For this one particularly right now today, we did not submit a request from CME to present as an ethics presentation. So this talk in particular, no.
So if there are no further questions, I'll just go through the process of you want to develop a relationship. This does not happen overnight, but you still want to be honest, candid, simplify what the diagnosis and prognosis would mean. Nicole, you want to say something?
Yeah, we had one more question here. Are the promotoras part of the care team?
Yes, so we just have our first promotora, Adriana, join our team. And she does participate in the huddle every day. And she is helping us with the social determinants of health and connecting with patients and families and trying to understand from their perspective what their preferences and wishes are. And from our side, she's kind of our bridge. So she will also help with educating and trying to simplify what their diagnosis is, what their prognosis is and all that. She just started, it's been a little over a month, but she is helping us with patients who need a bridge for us to better understand them and for us to provide care based on what matters most to the person and family.
Neela, this is Ross.
Yes, Dr. Lee.
Have you run into a situation where a patient, when they're alert, they've expressed a certain set of things of what they want at the end of life, and then when they become demented, their desires for end of life care, change? And if you have, how do you deal with that?
So as I said, Dr. Lawler, we have, and especially in the hospital setting, we have, where we do have the advanced directive say something, and then when the situation arises, they've changed their mind and they want everything. So we've had, if they are able to communicate their needs to us, we still follow what they say, because this is the only situation where word of mouth has no more value than a signed paper. So we do follow what they say. But if it is a person who's not able to communicate their needs and really not in the right cognitive frame of mind, then we do have ethics consult. We've had 2 physicians come in together. We've had psych come and evaluate and decide it. Also, you want to see, so basically following the ethical principles. Is it justified? Is it benefiting the patient? Is it not going to harm the patient? Is it, and are you still continuing to respect the patient's autonomy for the decisions? Because so one of the ways of having these conversations, because many times patients and people don't want to write down the advanced directives, is because they think that they are bound by what they write. But no, they do have the freedom to change, and they can change their mind. And even if it is written a certain way, when the situation is different for them and they change their mind, the word of mouth has more value, and we go by what they say, as long as it is an informed decision and they are capable of communicating their needs. Okay.
You can,
Any other?
I don't see any other questions unless somebody.
Okay. So here is a resource, and this is a free resource called Prepare for Your Care. It's in English and Spanish, where patients and family members can actually write down what their wishes and all are. EPIC also has an advanced care planning tool and patient wishes and preferences that the patients can fill out via My Charm. The Prepare for Your Care is a wonderful resource, and as long as it's used only for healthcare, it's free. Only if we use the data for research, then there is some guidelines that we have to follow for that. And then despite all of this, primary care may need the support of a supportive care team and palliative care physicians and palliative care team. So you can consult anytime, especially when it's more time consuming, the patient and family need a lot more support to listen and guide them through the trajectory of the conditions that the patient has. You can always consult palliative care for that. Okay. I just wanted to end by saying there's a lot of difference between hospice and palliative care and supportive care. Hospice is basically whenever a person has a diagnosis and a life expectancy of less than 6 months. Many people have a negative connotation to hospice and thinking hospice means giving up, but hospice actually means hope. It is opportunity to bring a sense of closure for whatever time you have left. It is support for not just the patient, but also the family. It is very person-centered and person-driven. There is an entire team of people with the hospice to help the patient and family. It's compassionate care and empathy, just putting yourself in that situation, because the only guarantee we all really have in life is that life is going to end. We're all going to die someday. We don't know when, we don't know how, but we know that we're going to die. So that's the only guarantee you have. You just want it to be, as long as you have life, you don't want to focus on how you're going to die. You want to focus on how you. And supportive care is really person-centered goals. You really want to focus on what matters to the person and family, what their preferences are. Because preferences happen based on who we are, how we've grown up, what work we've done, they influence people who've had influences with us in life. And they can change, but it's important for us to know that. So every time you want to ask, we have a lot of patients with advanced directives. Every year, we at least ask them once during the wellness visit. So are your advanced directives the same? Are your preferences and wishes still the same, or are there any changes? You don't assume that once they've done it, it's done. Then you want to really focus on quality of life and not the diagnosis. So really, many people try to treat people differently just because they have cancer or dementia. And I said, the person is the same. You just have a diagnosis today. Why are you taking off your focus from the person to the disease and a diagnosis? Why don't you just focus on the person? And supportive care helps a lot with advanced care planning in the very seriously ill persons. Okay. So the impact, so when we have healthcare based on our wishes and preferences, then we are going to not inappropriately utilize the healthcare services. We're going to have better functional outcomes, better quality of life, and better control of chronic conditions. It improves everybody's experience, patient, family, and the healthcare team. It really, we try to prevent and avoid difficult situations when we start having more and more discussions about advanced care planning. Just helps everybody live with respect and dignity. So this just shows the trajectory of, this was just a hospice benefit, but if you involve supportive care earlier, you're not just providing life prolonging care, but you're providing supportive care for a better quality of life. Any questions?
I do want to let everybody know that I did put the resource, the Prepare for Your Care resource, in the links if anybody would like that. Do we have any other questions?
Thank you. Thank you all. Thank you, Dr. Pursani. I don't know if he's there. I did see him get.
I know he was on here for.
Yeah.
Well, thank you very much, Dr. Patel. It was very informative, very insightful. We really enjoyed your presentation today. Thank you.
Thank you.
Thank you, everybody, for joining.
Thanks, Neela, for an outstanding presentation. Outstanding.
Thank you, Dr. Lawler.
Ditto.
Thank you, Dr. Hepburn. Can I log off now, Nicole?
Oh, thank you so much.
Thank you.